Hello, I'm Luis Araújo from Alliance Manchester Business School. This short video summarizes the BJM paper I co-authored with Katie Mason from Lancaster University Management School entitled Implementing Marketization in Public Healthcare Systems, Performing Reform in the English National Health Service. We asked two colleagues for their comments on the paper. Philip Roscoe from the University of St Andrews and Mark Sparrow, a senior NHS clinician and honorary senior research fellow at Alliance Manchester Business School. Their views will feature at the end of the video. This paper brings together two topics, marketization and performativity. We draw on two meanings of marketization. The first is marketization as a process of transferring the provision of goods and services from the public sector to market-based arrangements. The second takes marketization as the work necessary to produce markets as functioning socio-technical entities. By performativity, we mean how elements from one or more export domains, for example, a theory, a model, are used to induce changes within a practical domain so that the world envisaged by the theory or model becomes progressively realized. Whereas the performativity of economic and management theories has recently received much attention, the performativity of policy has been comparatively neglected. Our focus is on how policy-initiated reforms are enacted. More specifically, we're interested in, first, the mix of models, ideas, and theories that reforms carry. Secondly, the accommodation resistances they encounter and how these act back on the reforms. And finally, the consequences that follow from implementing reforms. Our empirical setting is the Health and Social Care Act of 2012. The Act followed decades of efforts to open up the provision of public services to the so-called benefits of market behavior. In July 2010, a white paper entitled Equity and Excellence, Liberating the NHS was published. It set out a template for a fundamental transformation of health and social care through the introduction of novel organizational and budgetary arrangements. The Act envisaged that primary care would become a commissioner of secondary care services, using markets as well as the NHS. Following the debate surrounding the white paper, its transformation into a bill, its passing as a parliamentary act, and subsequent enactment presents a timely opportunity to follow a policy-led marketization process. From the outset, the Act seemed to be a controversial piece of legislation, and so it proved. The satirical inside cover of a King's Fund report on this slide gives a flavour of the sentiment at the time, as do the public demonstrations that protested against the Act. Our study unfolded over a period of 5 years, starting with the publication of the 2010 white paper. We relied on two types of data for our study, publicly available documents and interviews. The transit of the bill through Parliament alone generated a torrent of text, audio and video material, documenting debates, evidence-led committees and so on. We studied the health and social care specialist literature to provide us with a host of editorials, invited pieces and commentaries from practitioners and academics. The Department of Health produced fact sheets and slide decks aimed at clarifying and detailing particular aspects of the Act. And finally, institutions such as the King's Fund and the Nuffield Trust produced useful blogs and reports throughout the period of our study. We also collected a set of primary data consisting of interviews with NHS staff, including clinicians and senior administrators, and attended workshops that we found relevant to understand the reforms and their implications. Our contact with clinicians was particularly important as it provided a granular view on how the reforms impacted on their everyday practice. We focused on the formation and operation of clinical commissioning groups, the linchpin of the Act. General practitioners, given their gatekeeping roles in access to secondary care and their knowledge of patient lists, were seen as pivotal to commissioning. Commissioning was expected to help reduce the costs of health and social care provision, as well as innovate the provision and delivery of services. For both objectives, engaging private healthcare companies to compete with the public sector was seen as key. However, there was considerable ambiguity as to what commissioning meant. the newly formed NHS Commissioning Board produced a report portraying commissioning as a process involving transactional and transformative components. The transactional component was associated with routine purchasing and contracting issues, while the transformative function was depicted as involving clinicians leading change through service redesign and engaging with local stakeholders to define health priorities. Considerable skepticism was expressed about commissioning from the outset. A Kingsfund report commented, "Commissioning health services is a complex and difficult task, and no other health system in the world that we are aware of places as much emphasis on it as a means of driving improvement." We extracted three main findings from our study. First, clinical commissioning was put into practice through the deployment of multiple instruments, market devices, and theories in use. This process created a series of nested layers that continuously reconstructed what commissioning meant, adding situated knowledge to the prescriptions laid down by the Act. This bricolage, as we call it, was essential to transforming the system of provision while simultaneously generating a sense of continuity and business as usual. Secondly, the mechanisms that put the Act into practice were organized at different scales. The National Programme of Action, the national and regional organizational structures and management practices, and the local or regional commissioning projects. At each scale, different theories and market devices entered into circulation, as the commissioning model encountered different forms of expertise, experience, and types of problem. However, interventions at different scales were not necessarily coherent. For example, at the scale of the program, market theories suggested that choice and competition led to efficient and affordable provision, while healthcare theory suggested long-term investments in stable centers of excellence. Thirdly, the 2012 Act prescribed what agencies should inhabit the world, how they should interact, and what types of system-wide effects they should generate. Considerable effort was expended to specify what skills and competencies existing agents should acquire to turn themselves into the commissioners and providers envisaged by the Act. In the meantime, ill-equipped and increasingly conflicted agents availed themselves of what was at hand to bridge the gaps between what the Act prescribed and what was possible to accomplish.
Thank you for the chance to comment on this fascinating paper. It's built around a case study of the wholesale reform of the public institution, Britain's NHS, as it's turned into a market. I wanted to comment briefly on the performativity framing and story that the authors invoke. The authors characterize performativity as a process of bricolage at multiple scales, with misfires and unintended outcomes. In a way, I wondered why this was an interesting story to tell. The claim that regulation is performative, well, it regulates, of course, and the observation that performation is complex and overflowing and that conditions may be less than felicitous, that's well documented in the literature. Critics have demonstrated at length that such processes are complicated. So far, well. Yet I was struck by the observation, almost a throwaway line in the discussion of the paper, that as constituents resist the programme, they turn to the very things, these very theories at hand in order to help them navigate problems. This idea of theories at hand hangs throughout the paper. Despite the lack of felicitous conditions, actors push reforms through. In the absence of a market, they themselves become and facilitate that market. What is being bricolaged? The concept and theory of markets. For me, this goes straight back to the power and the impact of performativity theory, taken from the original assertion, or the original assertion taken from Austin, that a world with a theory in it is not the same as the world without that theory. So we recognise that the process is complex, that it's socio-material and multi-levelled, but in the end there is still the theory. It's performing. And this, for me, is the real underlying revelation of the study.
There was a lot of trickle down of supposed market-like ideas, but when you actually tangled with it, when you try to get a feel for it on the ground, it was very slippery. And I developed the view really that two things. First of all, when people were enacting ideas of marketization, you know, this idea of customer choice and buying and selling and the patient being able to choose, all those sorts of ideas didn't seem to me to be particularly sufficiently sophisticated, either in terms of what the real world of clinical care is or in terms of contemporary service thinking of the time. So there was a disjunct between what we were sold as marketization and then what actually was what one might recognize as a sensible marketization idea. So it became quite clear that it was being enacted almost as a ritual. Nobody really understood what it was they were enacting. It was almost as if a grand theory of what the world should look like had been developed as a political agenda. So you've got these two problems. One is a very crude idea of what marketization is, and two, this wolf in sheep's clothing effect, whereas in fact it's a political thing that's been enacted, not a marketization thing. And there was some epiphenomena to that, if you like. So one epiphenomenon was, why could the ordinary patient not have choice about who commissioned their services for them? And the other epiphenomenon, if you like, was this feeding frenzy that went along with it. A lot of people who specialize in selling ideas into healthcare, into politics, lobbyists, consultants, all latched onto an aspect of that because they saw it as an opportunity for them to further their particular product, if you like, their idea, what they were selling into the marketplace. So huge fortunes were made in this feeding frenzy. And none of that has anything to do with people getting better. KPMG will come up with a system for governance for CCG because that's their role. Somebody else who might have experience in governance and how those sorts of things, they're precluded from the discussion. A bunch of GPs are given quite significant sums of money in order to undertake quite sophisticated purchasing operations. They look around for where they might get advice on that, and then there are people who are only too happy to help them with their models and their ideas. And so they bring their ideas to the table. It seems to solve the problem. It gives assurance to the political masters or the manager, the healthcare system, as it were. But at no point does it give assurance to the clinicians. At no point does it give assurance to the service users themselves. And so some of the things you highlight in the paper are very pertinent to this. So the person who was having their glaucoma appointment postponed, I don't imagine that was part of what KPMG imagined when they had their governance systems sold into the system, but that in effect was the consequence of using these kind of off-the-shelf models. One of the great ironies for me as a clinician is that a lot of work we do with managing complex cases, we don't particularly code or write up in models, but our insights and that experience is often appropriated by people in business thinking and service thinking, stitched up or webbed up into models, which then are transformed, go up the system, and they're handed down to us as things that we must take note of, as if we hadn't generated them in the first place. So people who put themselves in the market of purveying service user ideas are a highly selected group of people. They're not representative of the population of service users.
In this video, we have presented a summary of the core ideas behind our research. Together, these observations reveal the criticality of market and marketing theory development. If we can continuously develop our understanding of how market and non-market systems work, we can gradually become better at resituating and re-theorizing good markets in different and diverse practical settings.